Thanks for joining us, everyone. I'm David Glaser, and I'm here with
Katie Ilten,
Marguerite Ahmann, and Catherine London.
And we're here to talk about some of the questions that we get asked all of the time. And so you can send in more now. We've gotten a bunch. Some of them are just ones we hear all the time. Very few announcements. At this point, we're not sure what we're going to do for the August webinar. It's possible we're going to take the month off like the puzzler used to do on Car Talk. One question for you, you get a survey afterwards. We're interested in whether you care about keeping the same date. That date next month is bad for a whole bunch of us. And sometimes we move it. And we're not sure if moving it is bad for you. So we'd be curious as to your thoughts on the survey. If you are, is it nice to have it the same date every month? Or
as in the second Wednesday of every month. Do you like that, or does it matter?
And that's, thank you for keeping me clear when I am not, which, because I'm old, I'm not. All right. The only other thing is, if the sound goes bad, you can dial in. Robert is sending out the way you do that. So I am here with 3 colleagues, and what's amazing is that despite the fact that there's a boatload of brain power in this place, it's not even half of the brain power of our department, because I'm lucky enough to work with a bunch of people smarter than me, but we are here to whip through a bunch of questions. The first question. There was a settlement, a really big settlement. I'm going to not get the exact number. I want to say it's $156 million, where eClinicalWorks was in trouble for its meaningful use system, that basically the system wasn't compliant with meaningful use. That's not actually the part we're going to talk about. There was an element of that settlement that I would say I found surprising. The government criticized a referral program where eClinicalWorks would say, hey, if you refer us to a friend, we'll give you $500. And according to the complaint in which the government intervened, it was a false claims action, between 2.2 and 4.6% of new customers came from this referral fee, or I think would be probably a more accurate way of saying there was a referral fee paid in those cases. And I was a little surprised when I read this, because I said, are these really referrals? I mean, the anti-kickback statute makes it a felony to pay for an item or service that is, I meant to bring the language with me, but it's paid for by a federal health care program. And so there's an interesting question here as to whether the meaning, is if you're paying for someone to sign up with eClinicalWorks, is that something that's paid for by the federal healthcare program? So, Ms. Ilten, I'm curious as to, I kind of was like, I don't know, this seems aggressive for me. I'm surprised to see it. What's your take?
I think it's aggressive too. I was just looking in the language of in a kickback statute. It's to offer or pay or receive remuneration in order to induce or reward the referral of business reimbursable under a federal health care program. So I guess the government would have to be saying that the business here is the meaningful use of electronic health records, which actually it is reimbursable by a federal health care program, because the statute sets up a payment, per year payment, for hospitals and practitioners who do this. So I feel like it's not a crazy position to take, but it's aggressive.
And for example, a classic kickback would be if I pay you $5 to go see Dr. X, right? We all agree that's a kickback. And we'd even all agree, I think, that if I pay you $5 to use medical device Y, that's a problem. And if medical device Y is part of a DRG, there is no direct separate payment for that medical device Y. It's, whether you use medical device Y or no medical device may not, I guess it depends on the totality of what's going on, but it literally could have no impact on the DRG. So I think the reason we're putting this in is there's a lesson here, which is, I would have generally said that if you buy a copy machine and there's a referral program for it, that you don't have a problem under the anti-kickback statute. And I still think that's probably right, but I don't know if the government would agree. I think that they might say, if you've got healthcare stuff and there are the programs that are common out there in the world, in the non-healthcare world, they might be labeled as kickbacks if you apply them in the healthcare world. And that principle is one that isn't new. That's been true for years, and it's what makes healthcare weird, especially for people who come new to the industry. But I would still say this was a bit of an expansion from what I saw.
Yeah, well, and it's something to think about as incentive programs continue to be used by the government to induce certain behavior. So they could be said there's payment for those services.
Okay, next question. And because this is a hodgepodge, we're not terribly thematic, but that's okay. So should I do self-audits during an outside audit? And my view on this has evolved over the years. And now I feel pretty strongly that the answer is no. I generally would not. And let me explain why, because this is a little counterintuitive. It's nice to use the time when someone's looking at your stuff to prepare, right? Why wait till the last minute? I hate waiting till the last minute. It stresses me out. I'm an early doer. Now, there are two reasons I'm not a big fan of doing this. One is it's just cheaper. I've got a bunch of situations where we send stuff to the government and then literally never hear from them again. And if you haven't hired a consultant, you save money. That isn't necessarily the real reason I do it, because sometimes that's money well spent. Here's the real reason I do it. You've got 30 charts being reviewed. You send them out. I will say with a high degree of confidence that your reviewer will find fault with some of those. And I will say with a high degree of confidence that the ones that reviewer will fault will not be the same as the ones the government reviewer will fault. Those Venn diagrams will not overlap. Under the 60-day rule, there is an argument that as soon as your reviewer has faulted the chart, you need to refund the money. And so you're waiting for the results from the government. If 60 days elapse and you haven't refunded, you may have a problem there. And if you do refund, what happens when the government reviewer comes back and thinks that the ones that your reviewer criticized were just fine? And so for that reason, I tend to think get your consultant ready to go. Identify them, have them engaged. You're ready to go the moment you get the results, but wait until then. So that's my gut. And at this point, I would say a pretty strong gut. We could have gut comparisons as to how
Strong.
yeah, I don't know. We're all quirky in our way. So when does the 60 days start to run? We've covered this a lot, so we'll do this one really quick. It does not run when someone calls and says, I think we have a problem. That's not when the 60 days starts to tick. The 60 days starts to tick when you've quantified the amount of money at issue. You get a reasonable amount of time to figure out how much you owe. Actually, to figure out, A, is there an overpayment, right? Someone calling up and saying, I think there's an overpayment, doesn't mean there is one. You get time to figure out if there is one or not and quantify it. And the government presumes that 6 months is probably okay. It's not etched in stone. You, in theory, could go longer, but you don't want to be dragging your feet. And I would say, ultimately, the question is, if you've got 20 of these, if they all take more than 6 months, I'd be way more worried than if you have 20 of these and 19 of them were done quickly and one was complicated. All right, so the 6 months isn't a line in the sand, it's a thing. Can you do gain sharing? So this is really a question for physicians primarily. I suppose others could gain share. And the answer is yes. This is really clear that federal law allows you to do gain sharing. First, labeling here is weird. People call gain sharing different things. Sometimes it's called co-management. I am partial to shared savings. All of those terms refer to the idea of a hospital saying to a physician, if you help us improve the delivery of care or lower costs or both, we will pay you for that work, okay? And there was a time when, especially when it was things related to the lowering of costs was considered illegal because of a federal statute that prohibits a payment that is intended to reduce medically necessary services to Medicare beneficiaries. The law didn't change. But then that law was there. People said it prohibited gain sharing until the year 2000 or 1999, when suddenly, without a change in the law, CMS flipped and said, because that only applies to medically necessary services, it's okay to pay someone to reduce medically unnecessary services. And advisory opinions started to pour out. And there are, I don't know, 17 of them or 16 of them or something like that. So basically, gain sharing is illegal. It's very, I don't know if it's very rare, but it is not always true that we can say categorically something is illegal. Gain sharing can be legal, which isn't to say it's always legal. You could do it in an improper way, but it can be done legally. And CMS has even said that, pending further notice, they're not an enforcement priority unless the arrangement lacks sufficient program safeguards. And the kinds of things the government likes to see are caps on the payments, utilization targets. I'm a big fan of the third one, disclosure. If you're out in the open, it is a lot harder to criticize what you're doing. I mean, if you look at the federal landscape right now and some of the scandals that are out there, when you do stuff secretly, that's way more likely to get you in trouble. If everyone knows what you're doing, you first of all get the defense of, I didn't think it. Look, I was transparent. No one thought I was doing anything wrong. Within the gain sharing world, and I prefer to call it shared savings or co-management, people often think you can only do a deal for 1 year. And part of that is because of the 16 or maybe there might be now 17 advisory opinions out there, all but one are for 1 year, causing people to say, well, geez, that's a law. And it's like advisory opinions are a law, but it's also ignoring advisory opinion 1222, which was a 3-year term. And I got into a big tussle with a lawyer once because he said, well, that's a co-management deal. And co-management isn't the same. But if you read the thing, it talks about what the payment was intended for, was for things like if the physicians were not starting to use a cell saver or not opening surgical devices, and that was saving money, and then they were going to share in that savings. It was totally what many people would call a gain sharing deal. And I think that lawyer was taking a position because his client didn't want to pay for the work, and so he was coming up with a legal excuse to justify it. But he's wrong. Now, the challenge in here is the payment has to be reasonable. And so when you set up a long-term payment, the question is always, if you're getting paid 5 years from now for work you did today, is that reasonable? And that's a tougher question to answer. I don't always feel totally qualified to answer it, but that's the real question. There's nothing automatically limiting payments to 1 year. This is a question I think we get so often you can't count it. Can we give special deals to patients with high deductibles? And remember, we do have a whole pricing webinar out there. Actually, we had a whole gain sharing webinar too. There are a bunch of past webinars. And remember, all of our past webinars are available for free. If you want to ever send a link to one of your friends because you hate them and you want them to suffer through an hour of us prattling on, you can do that. But so there's a whole one about pricing. I was going to say pricing is complicated. I actually don't think it's that complicated. I would just say it's often hard to do what you want to do, which is a little different from complicated. The way implied contracts work are if you don't have an agreed on price, you can only charge what's reasonable. And where you get into situations where you're charging different people different prices, it can be problematic. If you agree on the prices, it's not. If Katie wants to charge me $10 for lunch and charge Marguerite $15, and we agree on it up front, neither one of us can really squeak. Well, we can squeak, but we don't have a legal claim. We can complain all we want to Katie, we can be mad, but we're not going to be able to sue very effectively. But if we haven't reached an agreement, and she's charging me 10 and Marguerite 15, Marguerite's got a pretty good argument. Hey, what's the deal? Why are you charging me $5 more than David? And that argument works in the healthcare context too. And so if you're doing this deal with someone who's got a high deductible, it allows like an auto accident insurer to come in and say, what, if that's your real charge to someone who comes in without a contract, why are you charging us more? And so intellectual consistency can matter on this. There are other problems that can come up if your rationalization for the discount is, well, we don't have to generate a bill. Remember that a lot of your contracts say that you can't have a billing fee in your charge. So you can't be trying to argue, or you have to be careful as to whether your price includes a billing fee. Or you'd say, well, it's the time value of money, right? This person we don't have to bill them and with collecting faster. There you can walk off the usury cliff, because if you're charging someone $80 for paying you today or $100 for paying you tomorrow, you've just charged, I don't know, that's not 20%, it's more than 20%, but a really high interest rate for a one-day loan. So these special deals for patients with high deductibles are a problem. Now, if you change it to a special deal for someone who's poor, I'm not worried at all. But trying to get the most out of people with insurance is potentially problematic. Can I accept outside referrals on my scanner? I think, Katie, this is one of the very first projects you and I worked on together, if memory serves.
I think that's right.
For a state in the far southeast. I remember that letter. It was a really well-written letter. And the answer is yes, you can. And there was this people thought you couldn't. And the reasons people thought you couldn't were that they were misreading manual language that is now gone. So it's really a double whammy, right? The language used to say that if a substantial portion of a group's revenue comes from outside referrals, you have to become an independent diagnostic testing facility, or IDTF. But the reality is, in any kind of group, there's never going to be a situation where a substantial percentage of the group's entire revenue is from outside it's from scanning from outside referrals, because you've got all the physicians.
Scanning, probably.
Yeah, exactly. Because it's all physician services are going to be the bulk, and so outside referrals will be minuscule. But that language is gone. So this is totally a myth. It lives on. It's resilient. Now, Florida is weird. You can just stop there, right? I did that any Florida, but if I were a TV talk show host, I would stop there. But I actually like Florida, or at least I've got a bunch of really good friends and clients in Florida. Florida has a state law that says you can't have more than 15% of your scans come from an outside referral if you're a physician in the state of Florida. To the best of my knowledge, that's the only state that has done that. So. An internal review found missing documentation. Do we have to refund? And so this has been a topic, I think I gave my first speech on this in 1996. So that's, what, 20 years ago? 21 years ago. You're going to make an old point. You're going to make an old joke about me again, aren't you?
Feeding me the argument.
So if Katie wasn't so good, I would hate her. But so the internal review is looking at documentation. And for Medicare, documentation is not the measure of a service. And if you have any doubts about this, we have a whole webinar on this one. Send any of us an email. We can send you a link to it. And our emails are on the back there. If it isn't written, it wasn't done is great risk management advice, but Medicare does not require documentation in order to bill for a service, asterisk. And the asterisk is there are specific documentation requirements for some teaching physician services and for some anesthesia services. Like for anesthesia, you have to document the elements. If you're doing medically directed anesthesia, you have to document certain things there. But Medicare doesn't require it. Medicaid in many states does require documentation, so you have to know about that. Private payers in many states require documentation. If you're choosing to do a refund, first be intellectually consistent in that. Like, I don't like the idea that if you find one chart with a problem, you'd refund, but if you found 1,000 charts, you wouldn't. Be consistent in that, and if you refund on this kind of thing, I would go right to the contractor. Did I miss anything on this?
No, except that maybe documentation of what happened at the visit is different than sometimes you need to have documents like plans of care.
Oh, that's an important point. Yeah.
There's a distinction you're talking about, but writing down what happened.
Well, and so we've done a webinar on written orders.
Right.
And so our written order is always required.
Definitely not always. Only in one circumstance.
Yeah, it's interesting because this is tough and there's inconsistent guidance on this. For example, when the independent diagnostic testing rules came out on Halloween 1997, they explicitly said that an IDTF needs a written order to do a scan, or to do a diagnostic test, more accurately, and no one else does. And since then, there is stuff out there that suggests diagnostic tests require a written order, and I think that's wrong because it was in the Federal Register in 1997. And so there is sometimes contradictory guidance on here, and this is a great example of where the risk management advice might differ from the do you refund. So like, what would you do, what would we recommend may vary from when would we recommend a refund.
And what type of service.
Exactly. Yeah. A device company replaces a defective device. Are there special rules? And the answer to this is yes. And I mention this because there was an OIG report about this a few years ago, and it keeps coming up. This only applies in the hospital world, really. Or I suppose in a surgery center, but actually, that's a good question. I don't know if this applies in a surgery center because it's in the hospital manual stuff, and it talks about the DRG, that if you get a discount where you pay half or less of the device cost, you've got to adjust your DRG. And there's some language in here about this. It's pretty specific. It's in the Medicare Claims Processing Manual. That's what the initials at the bottom there, Chapter 3, 100.8, and you can read along on this. So just something to note. Generally, what you pay for a good or service has no impact on what Medicare will pay you. That's another myth that's out there. Can I charge for something you get for free? And generally, you can, unless you're getting paid on a cost basis. And not many of you guys do, at this point, get paid on a cost basis for very much. There are some places that do, critical access care hospitals, and sometimes at various points might. But if you're on any kind of prospective payment, fee for service, or anything like that, what you pay generally doesn't matter. But there are exceptions, and this is one. Now, I'm going to turn it over to my young colleague, Katie Ilten.
Thanks, David. So speaking of free, we've talked about free transportation over the years and when you can provide it and what the OIG thinks about it. This is the issue with providing free transportation to or from healthcare providers is the federal anti-kickback statute, which prohibits offering or paying remuneration, so something of value to someone in order to induce them to come to you for federal healthcare program business, and then the prohibition against beneficiary inducement under the civil money penalties law. And then, of course, there are various state laws that may limit what you can do in terms of providing free stuff to patients. So there have been probably, I want to say, 10 to 15 advisory opinions over the years touching on aspects of free transportation, free lodging, sometimes it's accompanied with. And the recent development is that, effective just this past January, there is a new safe harbor to the anti-kickback statute and also some amendments to the exceptions to the CMP's beneficiary inducement prohibition that would protect certain types of free or reduced transportation programs. So we wanted to bring this to your attention, but also say that just because something doesn't fit in a safe harbor doesn't mean that it's illegal. So although this safe harbor is actually more expansive or permissive than I would have expected to see, don't rule out your programs just because they don't meet all of the requirements of the safe harbor, because it may still be a reasonable program that doesn't carry much risk. So what does the safe harbor allow? So it allows free or reduced transportation to, I guess I should say, by an eligible entity. And so eligible entity is really any individual or entity that primarily supplies healthcare items. And so this is hospitals, clinics, but it could also be Medicare Advantage organizations or ACOs could engage in these types of programs and get protection under the safe harbor. There was a fair amount of debate. The proposed rule said that home health agencies would not be included, but in the end they are. So it's a broad definition of an eligible entity. So how do you fit in the safe harbor? Well, there has to be a policy. You have to have a policy that you apply consistently across the organization and to patients. And the policy can't take into account, or say that the organization is going to take into account what the patient is going to get in terms of services, such that it would be taking into account the volume or value of referrals for federal program business. So that's kind of obvious. But you do need to have a policy. It can't just be kind of an ad hoc situation. To fit within the safe harbor, this can't apply to air transportation, luxury transportation like limousines, or ambulance transportation. So those things don't count for the safe harbor protection. You can't market the program. So you can't put an ad in the newspaper talking about your free transportation program. And during the ride, the language is a little funny, but it appears to say that the driver can't be advertising to the people on the bus or the shuttle or the car about the provider's business. I think the question that comes to my mind is whether you can have like a shuttle with a TV that's talking about the healthcare provider's services. And that's a little unclear to me whether that would be advertising during the ride, because the language of the rule seems to attribute the advertising to the driver. So that just think about what sorts of promotions you might be thinking about doing during this, because you might run afoul of that provision.
It's really the way I interpret it is that they mean advertising of the program, but I would probably say life's too short for that one. How important is it to you, for you to run your little video?
Maybe don't take the risks.
I think it's the next part that freaked me out the most, because you can only pay your drivers one way. I don't mean one way on the round trip.
Oh.
Yeah. But like you can't Uber. You can't do this as with an Uber.
Right. Not in a yep, exactly. Unless you're willing to kind of probably take a risk to pay them a flat fee and then maybe you lose on it, right?
Yeah. Basically, you got to pay your driver.
Hourly. Yep. It has to be. It can only be available to established patients, and that means that a patient has to have either previously attended an appointment at the provider or supplier, or they have to have selected and initiated contact to schedule an appointment. So they basically have to be on the appointment log in order to avail themselves of this service.
And I just want to interject there. This is one of the great examples of how language is confusing, because people think of what an established patient is in the CPT sense of the word. And an established patient is someone who has been seen by a doctor in the same specialty for the past 3 years. And they specifically said that isn't what they mean. It just uses the same word. So
helpful.
yeah, isn't it?
So there's a geographic limit on these types of programs, again, to get the safe harbor protection, not necessarily to be legal per se, or to not be illegal per se. So the patient has to be within 25 miles, has to be transported just within a 25-mile distance of the provider or supplier. If you're in a rural area, an area that's not a metropolitan statistical area, that's expanded to a 50-mile trip. So you can't be shuttling your patients around for things that don't have to do with getting healthcare services. So you can't be taking them to their other appointments for things that the provider or supplier isn't providing. So you can't be taking them, I guess, to their, I'm trying to think of another, dry cleaning, right? Doing errands like that. It has to be for the purpose of getting healthcare services that are medically necessary. Though the commentary to the rule does say that you may transport the patient back to their home. So you could take a patient back from the ED back to their home, for example.
Question for you, Katie. So I've got 2 campuses, and I want to put my particle accelerator at one of the 2 campuses. Do you think there's an issue if I transport people from campus A to campus B so they get their particle accelerator, they get their treatment there? Does that seem problematic to you?
Oh, I don't think so. I mean, you're going somewhere to get presumably medically necessary items or services. Not at all. The provider supplier has to bear the cost of the free transportation. You can't obviously pass it off somehow to the patient. And then outside of the, I guess, patient-specific transportation, the conditions for those that I just talked about, the Safe Harbor also talks about free transportation programs like local shuttle services. And those local shuttle services that's where you have shuttle services on a set schedule and route. And those are okay if they comply with the Safe Harbor requirements, except you don't have to have a policy about who's going to, get them, and you don't have to have an institutional policy, and it doesn't have to be limited to established patients. So in this case, with the shuttle services, you can have employees or families, right, or friends who are accompanying the employees can take advantage of the shuttle service, and that is not going to be a problem for meeting the Safe Harbor. The geographic constraints to the local shuttle services are a little bit different than the, I guess, patient-specific requirements. So on the local shuttle services, you have to have less than 25 miles between stops, and stops would have to be locations where there are services, that provide services. So you couldn't have a stop at one community center to the next community center, then back to the hospital. Your stops have to be locations where there are services provided. And then it expands to the 50-mile geographic requirement for rural areas. So those are the types of things and programs that are going to meet the Safe Harbor requirements and therefore have protection. Now, again, that doesn't mean that programs outside of the Safe Harbor are necessarily illegal. And in trying to assess those programs, you still want to look at the advisory opinions that are out there to see what may be tolerated. There are several advisory opinions on air transportation, and that's specifically not allowed under the Safe Harbor. But if you are thinking about that type of program, it's pretty limited in scope. It has to be for really high needs, and I think there has to be means testing. At least that's what the OIG said in those few cases. But as always, don't forget that there are options outside of the Safe Harbor that could possibly be illegal. So things to think about now are what the Safe Harbor does and those advisory opinions that have been out there from the past. Okay, we wanted to talk about ransomware because it's been in the news as of late. We actually had this FAQ in our a year ago in our July FAQ webinar. actually it was August. Well, anyway, a year ago, we talked about this, and in particular, we talked about the OCR's guidance from a year ago, almost exactly, about ransomware, as if they could predict the future. It would be worth spending 20 minutes rereading the OCR guidance, which we've linked here. There have been obviously some really big ransomware issues, and they have touched industry. And so while there are certainly many things to know on the technical side of ransomware and what sort of protections you should have, the compliance side of this is important too, because unfortunately, OCR says it's not if you get hacked, it's when. And so when that happens, you want to make sure you have all of your HIPAA compliance pieces in place. And so remember that ransomware implicates several parts of the HIPAA security rule. And if you have a ransomware attack and OCR comes in to investigate, they are going to be able to tick through to see if you have a robust security rule program by looking at these at least four types of things. The first and really important step to take is ransomware should be listed as a line item on your security risk analysis. The guidance starts out by saying that, and we've seen in OCR investigations and audits that if you don't have a good risk analysis that lists the threats and vulnerabilities to your PHI, you're probably not going to be in a good position to negotiate a reasonable, if there is such thing, reasonable resolution agreement with the government. So the ransomware should be on the list, no doubt about it. You should be...
I'm going to interrupt for just 1 second to say, because I don't really do the HIPAA stuff. You and Breyer and some other folks do that. And I am always surprised at the positions OCR takes and how good, how much work it takes for you guys to get them to a place of reasonableness. And so I just want to emphasize that it's hard to get to reasonable. Having watched you guys really struggle on that, you're making what seemed to me to be reasonable arguments and how hard it is to just say, wow. And I'm glad you guys do that so well.
Well, I don't hold my breath when I'm hearing about the incident that may lead to the investigation. I always, though, get nervous before I see the organization's documentation, and particularly with respect to the security risk analysis, because if we start out with a bad security risk analysis, one that isn't comprehensive or one that's been on the shelf collecting dust for several years, I know we are in a bad place. We're going to start out with a much higher penalty to negotiate, and we're not going to have very good arguments. So update your security risk analysis always, and specifically with regard to ransomware. You should be following the other security rule steps and requirements with regard to ransomware, just as you would with regard to any other security incident. So you should have a contingency plan. Ransomware makes data unavailable for indefinite periods of time, and so backups are particularly important. And in addition to those actual actions, OCR will ask, what's your plan for this stuff? Do you have a backup plan? Make sure if a ransomware attack happens or suspected, you're following the specific HIPAA security incident response plan that you're supposed to have. I won't get into the details, but there's actually steps in a plan that the rule lays out. And again, OCR will show us your security risk response plan and how you followed it for this particular incident. So I'm happy to talk with you offline about that. And we also want to know if you want to have a webinar on this, because we can get into the weeds and really talk about what you should have as well. So let us know if you want that.
We could also do one on marijuana if we really want to get into the weeds.
Yeah. Oh my.
Well, that was for Kevin Rich.
And then you should also be training workforce on signs of ransomware. And this should be part of your ongoing security training that you have. It's going to look much better to OCR, and you may avoid ransomware attacks if you have actually told workforce what to look for or how ransomware may come into your system. If you have had a ransomware attack, you're going to have to go through the breach analysis, which dictates whether you have to report to OCR and to patients. And so The breach analysis is largely the same as you would do for other potential breaches, but OCR has kind of weirdly added these 2 additional factors to consider when a ransomware attack occurs. And so make sure that if you're looking into a potential attack, you've documented these 2 additional factors. Is there a risk the data is unavailable? As I mentioned, unavailable for a long period of time, or is there a risk that the data is, the integrity of the data is compromised? My understanding is that ransomware takes data and then it can change it, and so you want to make sure the data you had before is the same as what you had after, and those are 2 more items to think about and consider when you're doing the analysis. Okay, switching gears entirely, we often get the question of what's going on with my pending case before that we submitted to request an ALJ to look at my Medicare overpayment case.
So speaking of old, Katie?
Yes.
Yeah.
This is a fair question. I will say I did just get a hearing notice for a case that was a hearing notice for Omaha for a case that was appealed in 2013. So right now, my little, I guess my anecdotal experience is that 4 years out, we're getting notices for hearing. And so what is being done about this? What's the status? Well, I guess I should say, what is OMHA, the Office of Medicare Hearings and Appeals? This is the office where the ALJs hear beneficiary and provider supplier appeals of Part B claims and Part A claims. So back in December, there was a court order that basically said that OMHA needs to reduce its backlog by percentages, each year, getting to 2020 where they would be up to speed and up to date. There was also, I think, on the heels of that, the CMS issued a final rule that took some measures to basically kind of help move the process along. Won't go into those in detail, but we will be seeing that now that the Departmental Appeals Board, which is the top governing, the top adjudicating body on these, will be able to designate the Medicare Appeals Council decisions, which is the next level down. Some of those are going to be precedential. So that means that there's going to be a body of decisions that CMS and its contractors should be able to rely on as precedents in issuing initial determinations and redeterminations and reconsiderations. So that's supposed to help move things along because questions that are raised in appeals should be answered by some of those decisions.
But one thing I'll just mention, because I'm on Monitor Monday, and this past week, Monitor Monday had Judge Griswold, who is a really good administrator there on, and she was talking about this, and I think I have these numbers right. I believe they issue 90,000 opinions a year, but 180,000 appeals are filed a year. And so just if you look at this mathematically, and they're trying to increase the number of judges, but the backlog has to grow at that rate still.
Yeah, it's going to grow.
So
they're trying to add more people to be adjudicators. There's a little bit about statistical sampling, and I'm not going to get into that, but if you happen to have a sample where you have a sample of claims, but the claims are being decided not at the same time. We haven't seen that. You're going to be in a situation where you can challenge the statistical sampling, and you're going to have till the end of the last date that the last decision is decided to appeal. So it's a timeline issue. In May, the fiscal year 2018 proposed budget does request a lot more money than last year to address this, and maybe there will be a congressional effort to fix this. But right now, I think the actual OMHA has said it takes 1,000 days to adjudicate a provider supplier appeal. So we are still way behind. This is kind of an oldie but a goodie. Can we release medical records we received from a third party? I get this question a lot. People are concerned that if they got records from one patient's referring physician, patient comes in, asks for their records, client thinks that they can't send the records from the referring physician because they're not the client's records. In fact, under HIPAA, PHI includes health information that not only you, the covered entity, have created, but also the information you've received or maintained. And so a covered entity has to disclose PHI in a designated record set if it's requested by the patient, and that designated record set would include information from outside providers if it's part of the records that are used in making treatment decisions of the patient, so, or about the patient. So yes, the answer is yes, you can disclose medical records from a third party, with one exception being federal CFR Part 2 alcohol and drug abuse facilities. Those records are not to be redisclosed, but they should be stamped and identified as such, so it should be pretty obvious that you can't do it. There could be state law considerations. I haven't seen a lot of state law issues. Minnesota's stricter, so folks in Minnesota, feel free to call and we can hash that out. But in general, the answer is yes, you may disclose records from a third party. And then another classic is that we continue to get is, do Medicare rules apply to, it says MA patients, Medicare MA patients, which is Medicare Advantage patients. So I think this question is most, I guess, most practical and important when you're looking at refunding money. On a go-forward basis, you typically don't know who's a Medicare patient or who's a Medicare Advantage patient, so you're not going to change up how you treat them on the ground much differently. But if you're looking at a refund, you want to know if you didn't meet a particular Medicare rule and you have to refund money because of it, always assess whether that's actually true. Do you have to apply those same rules for Medicare Advantage claims? And so we've, I think both David and I have tried to figure this out over the years. There's no regulation that expressly says Medicare, traditional Medicare rules, let's say, for example, physician supervision rules for diagnostic tests. There's no regulation that says rules like that apply to Medicare Advantage claims. And in fact, there are different sets of regulations that apply to Medicare Advantage than to traditional Medicare. So there's no regulation that says it does. If you ask Medicare Advantage if traditional Medicare rules apply, they will say ask traditional Medicare and vice versa. So that's not particularly helpful, although we haven't made those calls in a little while, but I don't think anything's changed. The really big important things to know what applies to Medicare Advantage is to read your payer agreement and the provider manual. And if there's nothing in your payer agreement or provider manual, if you've looked at both of those things, then I would say that's the universe of rules that applies, particularly when you're looking at a refund. Now, Stark may be a different story. I think we always actually assume that the Stark rules apply to Medicare Advantage patients, and so that's sort of a separate question. So if you're if you have a Stark issue, keep that in the back of your mind.
And the only thing I'd add, it took me years. I'm embarrassed I didn't think of this right away, but Medicare Advantage plans can have benefits that are more generous than Medicare, and that kind of by itself proves that Medicare rules don't automatically apply. So
I should say, at least Medicare Advantage doesn't tell you to consult your lawyer, which is my favorite response that we get quite often when calling regulators.
That helps.
I'm going to shift on to a hot topic recently, which is networked medical devices and the risks that these devices can present to healthcare providers. In recent years, there's been a growing emphasis on cybersecurity generally, but also in the medical device context, given the increasing number of devices that will actually connect directly to the internet and to provider networks and EHRs. So this has created a lot of issues and risks for providers as well as manufacturers, but we get more and more questions on this topic today as regulators have become more interested in this area. FDA has issued some guidance and also warnings recently, which have kind of warned providers and the public about vulnerabilities of particular devices that it feels are especially vulnerable to hacking. Most recently, we've seen this with St. Jude and their Merlin transmitter with one of their implantable cardiac devices. And also the OIG work plan the past years has addressed oversight of network devices as one of their focuses, calling out particularly dialysis machines, radiologists, radiology systems and medication dispensing systems as particularly vulnerable. So what are the risks? There's a real risk to patient safety because devices like insulin pumps and pacemakers can be compromised by hackers or viruses, which could affect the operation of the device or even stop the device completely. So this obviously also gives rise to a lot of regulatory concerns, and particularly in the HIPAA context, because these devices will generally collect and transfer electronic PHI to either the device manufacturer or a vendor. The information is often stored in a cloud or sometimes even transferred outside of the US. So there are a lot of issues to unpack here, and we're just kind of skimming the surface, but this obviously also gives rise to potential reputational risks if there's a patient safety issue or a breach. So what does this mean for healthcare providers? You have to know your vulnerabilities and be prepared for a breach. And the vulnerabilities will really differ depending on the type of the device, the age of the device, exactly what data is transmitted and how that data is going to be used. So legacy devices in particular are older medical device models that are still in use, which can present a lot of risks because they might not have the software updates or patches needed to ensure that they'll be secure. And for these, the focus really needs to be on updates and firewalls and patches, whereas with your newer devices, providers really want to focus on the procurement process and adequately assessing vendors in connection with that process. Also more and more important to have procedures in place for tracking and disposing of devices. Really the key issue though, I think, is to know where the data is going to be transmitted and stored and who is going to have access to this data. So manufacturers will also, or will often outsource some of their functions overseas. So providers oftentimes will try to prohibit that via contract. And obviously in light of these risks, it's really, really critical to have the right contracts in place and make sure that those protect you from these risks. And those might include, business associate agreements or in ISAs. And you need to determine what's the right contract for each particular situation. Whether a business associate agreement will actually be required is one question that we get from time to time from our clients. And then we also have a lot of clients that are increasingly relying on information security agreements and will insist on having these even in addition to BAAs. So as Katie mentioned before, risk assessments and having incident response plans are becoming more and more important, especially with these new ransomware and other cybersecurity risks that come up. And again, this is a really big topic. We're just skimming the surface, so happy to follow up if you have other questions here. Shifting gears again, since we bounced around quite a bit on this webinar.
And actually, I don't remember if we started when you started, if you were Catherine. I don't remember if when, did we?
Oh,
yes, I don't know if we.
I don't know.
When we made the,
yes.
when we made the change, I don't know that we said. We did?
This is Catherine London.
Oh, well, in case there's any question remaining in your minds, this is Catherine. So thank you, David. I wanted to give a quick update on the semi-annual OIG report to Congress that came out recently. This is a report that summarizes the OIG's work during this 6-month period from October to March of this year. And it just highlights a number of the OIG's efforts during that period. And in particular, the report this year highlighted a couple key focuses from regarding improper payments, including payments to that providers payments made to providers after a beneficiary's death. I know we've gotten a number of questions, or this is an issue that comes up from time to time, more often than we would expect, actually. Also discussed express lane, monitoring of express lane eligibility for Medicaid enrollment, improper payments for incarcerated beneficiaries and for chiropractic services and cochlear devices. Some other noted efforts included prescription drug rebates from pharmaceutical manufacturers, and this is for states that aren't adequately handling and making sure that they're getting these rebates. Also mention the OIG's efforts to determine whether states are verifying nursing homes have corrected deficiencies that are identified during state surveys, with Arizona being the state that it called out specifically as not having requested sufficient evidence in the past. And then finally, OIG continues to monitor CMS's management of the quality payment system and its oversight of that, and basically ensuring whether there's enough guidance provided to providers. And then moving on, once again, a question we get from time to time is whether physicians can charge patients fees for completing patient-requested forms. So these might be for disability-related requests or for school activities, and some practices will charge anywhere from $10 to $50 for time spent by providers completing these forms. So these types of charges might be appropriate in certain circumstances, but there are several things that you need to consider to avoid getting in trouble here, especially with your payer contracts. So first and foremost, you need to make sure that the fees are not, that you're not charging patients for something that's part of a covered service you're billing to payers. This is especially important, obviously, for physicians participating in Medicare, since Medicare prohibits participating providers from requesting any payments for beneficiaries for services that are covered by Medicare. And there was at least one instance in the past where a group had, I think it was a couple years ago, a medical group had charged a $50 administrative fee to patients to compensate for the increasing amount of paperwork that they are required to fill out. And OIG had said that, alleged that a portion of this fee actually did constitute payment for Medicare covered services, and that the group was prohibited from asking for these charges. So similar issues will obviously arise in the commercial payer context if a payer considers the form completion as part of a payment for covered service. So you really need to be careful and to check all your payer contracts. Obviously, you need to be mindful of state law and board policies that could restrict these practices. And local customs might come into play as well. I know the AMA has previously stated that physicians should complete simplified forms without charge, but can charge for more complex forms in conformity with local customs. So a couple final thoughts on this is that the rules might differ depending on the type of form requested. So if it's an FMLA form or other things like that, you might want to double check there. And then in any event, you should make sure that the patients have notice in advance. Moving on to Marguerite.
Thanks, Catherine. All right, so I'm going to cover a few other HIPAA-related items or kind of things on people's minds, one of them being the HIPAA audits. OCR is currently in phase 2 of the audit program, which are a round of desk audits for both covered entities and business associates. A few of us here recently attended a presentation by OCR, and they described these HIPAA audits as a free consultation. So I think they were being a bit cheeky with that. But they see this as a way for OCR to provide feedback on a covered entity or business associate's compliance efforts. And their intent in doing these audits is not to impose penalties. That said, they did note that it is possible to move from an audit to a compliance review, which is the actual mechanism for imposing some type of penalty based on a covered entity or business associate's behavior during the audit. So some of the examples that they noted was if you just don't respond at all, or if you send in documents that make it look like you have literally no idea what you're doing, then you're likely to be moved from that audit track into the compliance review track. And so some key takeaways are to obviously respond and to be able to showcase that you not only have compliance policies, but that you're also following them. The next step in this audit process will be for OCR to publish a summary report of the desk audits, and then they'll follow that up with some on-site audits. As of the last we had heard, OCR was not sure if the on-site audits would be coming before end of 2017, so we're still sort of just waiting on that.
I wonder if the OIG will start characterizing their subpoenas as a free consultation.
Free consultation, yeah, so nice. They did laugh while saying it, so I think they understood. A couple of things that have come up from the audits so far. First, we're kind of noticing that they are finding fault where we would not have necessarily found fault ourselves. One key example of this is whether your notice of privacy practices is prominent enough on your website. So one covered entity was dinged because it was at the bottom of their homepage. And so apparently OCR does not feel that at the bottom of the page is prominent enough. Another thing that they've focused on is whether or not a covered entity has contact information for business associates. So you want to go through and make sure that you have emails and phone numbers for your business associates. All right, so kind of piggybacking on what Catherine was talking about earlier regarding fees, I'm going to cover a few common questions that we get with regard to charging for access to medical records and for providing copies of medical records to individuals. So about a year ago, OCR published some additional FAQs and a quote-unquote clarification. And so the general rule under HIPAA is that an individual has a right to access their own PHI. The clarification that they've made in this latest round of FAQs was to say that individuals can also direct a third party to receive a copy of the individual's PHI under this same right of access. So therefore, that request does not require an authorization under HIPAA. It just requires a written request. And then it would also be subject to the same fee limitations that apply under the individual's right of access under HIPAA.
Just Marguerite, forgive the dumb. What's the difference between an authorization and a request?
So an authorization is a sort of specific beast under HIPAA, and it requires certain things to be outlined, whereas a request by the patient can be as simple as, I, Marguerite Ahmann, request that my full record be sent to David Glaser, and that's enough. So moving on to what you can charge, OCR has gone to painstaking lengths to describe just how restricted a covered entity is from assessing fees for records. So under the rule, a covered entity may charge a reasonable cost-based fee, but this is further restricted by the fact that this can only include labor, supplies, and postage. So the labor can only be for creating and delivering the records. That cannot include any time spent searching for or retrieving records. You can charge for supplies, but you can't require anyone to purchase a USB drive if they actually requested that the information be emailed, and you have the capability to do that. You can assess a fee for the labor of photocopying and scanning into an electronic format, but OCR notes that they expect these labor costs to be incredibly small. OCR has also said that you cannot charge for a patient to just select the view and download feature from a patient portal. Many states have their own fee schedule, and OCR has been very clear in saying that any fees authorized under the state schedule are not permitted if they go above the fees permitted by HIPAA. OCR has also gone as far to say that you really should be providing a copy free of charge. And again, if state law dictates that one copy of the record or a copy in certain circumstances have to be given to the patient free of charge, then you have to follow that more restrictive state law. OCR sees charging patients who can't afford to pay as particularly problematic, so you want to be cognizant of that when you are assessing fees for records. So in all of this, OCR outlined 3 different methods for calculating your charges. You can do actual costs, subject to those limitations that I already discussed, an average cost, or you can do a flat fee of $6.50 for electronic copies of PHI that you maintain electronically. So then that begs the question from a lot of covered entities out there whether OCR was actually setting 650 as the new maximum. And so then they had to put out another clarification that really clarified that it's not the maximum. This is just an option for covered entities who don't want to go through the analysis of figuring out the actual or average costs or assess the reasonableness of the fees that they are charging. Regardless of which method you choose, it's really important to notify individuals in advance, just like Catherine was talking about, for those forms. In all cases, you want the patient to know what they're going to be charged. So a common question we get, and a very confusing aspect of this, is then differentiating a true third-party request from an individual's request. So on that, OCR hasn't provided a ton of guidance. We recommend that you look closely at each request to determine whether the third party is relying on a broader authorization from the patient, or if it's really just a request forwarded on from the patient by the third party. And if the latter is true, then the fee schedule or the fee limitations imposed by HIPAA do apply. You can require requests to be in writing, but you cannot create a barrier to or unreasonably delay access to the information. So you can't require an individual to have to come to your offices or to mail in a request. Those are things that OCR has said are unreasonable. And again, as I mentioned before, you cannot require that full HIPAA authorization. And OCR has also noted that you have to verify the identity of the requester, but again, you need to weigh that against not having unreasonable procedures that would somehow limit the individual's right to access. A final note here on sending records via unsecured email. For most covered entities and for most patients for that matter, this is not the ideal method of transferring records, but the patient does have the right to request that a record be sent via email. So, for instance, if they don't want to log into their patient portal to download a copy and they request instead that you email it to them, you have to respect that request. OCR has said that you should give them a light warning about the security risks, and then as long as it's from the request of the patient, the covered entity isn't responsible for any disclosure while in transmission. We are at the top of the hour, but I'm going to keep on going. Lucky you guys. So I'm going to touch on the Medicare Outpatient Observation Notice. This requirement was under the Notice Act and was enacted back in 2015. So it requires hospitals to inform specifically Medicare patients who are receiving outpatient observation services for more than 24 hours. And they have to be notified of the fact that they are not an inpatient, but in observation status, and then explain the implications. So CMS has a standardized form for this called the MOON, the Medicare Outpatient Observation Notice, and that's required to be given within 36 hours. You also have to verbally discuss it with the beneficiary and have the Medicare beneficiary sign it. So one of the key questions that we've gotten then is, when am I supposed to deliver the MOON?
On the day of the eclipse, which is one of the reasons we're not having maybe a webinar next month, is there is the August total solar eclipse, August 21st. See you all in Kansas. Sorry, Marguerite.
We'll be
Please continue.
So first, I would recommend that you check with state law to make sure there aren't any notice requirements. For instance, Minnesota has a law that requires hospitals to provide notice, a similar notice, but it has to be given to all patients, not just Medicare beneficiaries, and that one has to be given within the first 24 hours. So you have the Medicare one that says you have to give the notice to anyone who exceeds 24 hours of observation status, and then a state law one that you also have to work within. So make sure you look to your state and try to reconcile the two. CMS provided some commentary in response to questions about whether it can be given in the first 24 hours, specifically in light of some of these state requirements. And they indicated that you certainly can, but you cannot give it right away. You can't give it at the initiation of observation services. They want the patient to have spent a little bit of time in observation status. They want them to have gotten over the initial chaos of entering the hospital and signing kind of the standardized forms. So I've put up a quote there that is from the preamble to that final rule.
It's Goldilocks and the Three Moons, right? You can't do it too early, you can't do it too late.
It's got to be
just right.
Just right.
Does that mean that people don't read the forms at the beginning?
Another law that I wanted to point out is the Elder Justice Act. So this was enacted along with the ACA in 2010 and is designed to protect the elderly from abuse, exploitation, and neglect. And the Act specifically imposes obligations on long-term care facility owners and operators to provide an annual notice regarding these reporting obligations to covered individuals, which are employees, agents, and contractors. And then those covered individuals are required to meet these reporting obligations under the Act. So while this webinar is designed for hospitals and clinics, we've seen this come up in contracts with providers who will be providing services to long-term care facilities. And so they've included language regarding the Elder Justice Act in the contract and then appended the notice to serve as that notice that they have to give to contractors. I will point out that providing the notice in the contract would not relieve that entity of its obligation to continue to provide it on an annual basis, but this is kind of some new language that we've been seeing pop up, so we wanted to make people aware. Another question that we've gotten is what's up with Section 1557? For those of you that are familiar, that is the non-discrimination provision of the ACA. It went into effect in 2010, and then in May of 2016, we got the final rules. But it wasn't too long after that, on December 31st of 2016, that a district court in Texas issued an injunction which prohibits the federal government from enforcing specific discrimination provisions that apply to gender identity and termination of pregnancy. So what's happened since then is in May of this year, I believe, the DOJ filed a motion, what's called a voluntary remand and stay, and so they're pausing litigation and sending the regulations back to HHS for further review in light of the court's decision. So at the federal level, we're really waiting on some possible revisions to the rules. In the meantime, OCR has put out a statement that says that it will continue to enforce the other important provisions, so any of the other non-discrimination provisions that apply even to sex discrimination, but not those specific subclasses, which were gender identity and termination of pregnancy. What's also important to note, though, is Section 1557 also includes a private right of action, which is not impacted by this injunction. So we're seeing the number of discrimination cases which are citing Section 1557 as at least one of the bases of fault kind of rapidly increasing. So it's something to keep on your radar. We just wanted to give a very quick reminder about the QPP reporting period, which reporting will be due in March of 2018. They just published a proposed rule on the QPP program for 2018, so we will report back later on what the final rules say for that.
Okay, we've got one more question here and then two that have been sent in, and then we'll wrap this up. So all charts have to be signed, right? No. The rules vary based on payer. And actually, this slide is wrong, I would say, because Medicare doesn't require signature as a condition of payment in the clinic setting, Medicare can require a signature as a condition of participation in a variety of settings. And so that's one thing to keep in mind. It's one of the things that makes questions here hard. Is this required? Well, is it required to get paid, or is it required, to be licensed? Is it what's it required for? And the answer can vary. So, but Medicare's manual makes it very clear that if you're missing a signature on a medical record, you can get an attestation to fix that. And that would make no sense if, in fact, a signature was a condition of payment on a physician record, right? Then the attestation provision would make no sense. Now, the other part of this it talks about signatures from orders and seems to suggest that if the signature is missing from an order, you're toast. As Ms. Ilten alluded to earlier, things aren't really that simple. And I guess here's how we would boil this down. It's better to sign than to pay us to get you out of trouble for having not signed. So from a risk management perspective, sign. But if you find an unsigned chart, I would not be refunding money on the missing signature. I once had an overpayment, $3 million for a doctor in the desert Southwest, and his supposed sin was not signing chemo administrations. And we wound up, actually his overpayment at the end of the day wasn't $3 million, it was about $3,000 when we got done with it. Slightly different. All right, so Katie, I know you've got a question that was asked about free transportation.
Yeah, I have two questions here on free transportation. So the first is, what if your patient is in a rural area and the clinic is in the city? So I think this person is saying, does that 50-mile rural geographic limitation apply? How does it apply based on the location of the clinic or the location of the patient? And so I probably didn't say this clearly enough, but where the patient is what determines the geographic restriction. So if the patient is in a rural area, and it doesn't matter where the clinic is, the patient can be transported up to 50 miles to the healthcare provider.
Okay, I don't know if I do not remember this, so I'm hoping you do. Is rural under this rule outside of a metropolitan statistical area, which is what I think? Yeah, okay.
And then the other question is...
for people who struggle with that, so, because this comes up for Stark and some other things, there's rural and there's urban. And you can find this on the census. We can send you a link, but basically the census breaks it on a county level. So it's not just, are there cows around is not the test, right? Or for people on the East Coast, it's not every place in the Midwest. It's a county by county thing, and it can change. Mankato in Minnesota, sort of like you move as your county becomes urban. So,
thank you. Yes. The other question is, so can the company logo be on the van transporting the patients? So good question. This gets to the requirement for the safe harbor that there not be marketing or that there not be advertising during the transportation. And so actually the commentary to the final rule says that signage designating the source of the transportation on vehicles used to transport patients, i.e. names of the provider or Uber, but you can put your name on the vehicle. That's an important safety feature and would not be considered marketing. However, they say, we disagree that providers should not be able to post signs or give patients pamphlets or other marketing or informational materials during the transport. So any discussion about services that patients may receive should come from the healthcare provider or supplier, not the transportation provider. So I think this is where you don't push it by doing info videos or pamphlets or brochures in the car or in the van. Just leave it to the signage on the vehicle.
I think I'm going to set up a clinic called Glaser's Free Transportation Clinic, and then I can put my logo on the side.
That would be okay.
All right, I got one quick question, then we will wrap this puppy up. So we should not bill insurance in high deductible cases if we accept a cash payment and discount, right? And I would say you got to be real careful in there. There's a lot going on. You certainly don't want to be double billing. I don't understand enough of the nuance of what's happening there to fully answer that one. And I'm assuming you're not enrolled with the high deductible insurance. If you are, you got to be really careful with the contract. So I don't think we're going to do an August webinar. I just want to remind people as they fill out the survey, and we need to fix our evaluation and shorten it down a little. But we're really interested, A, in topics that you'd love to hear covered, and B, is it better? I mean, I could see an argument, maybe this day is a pain in the butt for you, and it'd be nice to change days periodically, but we've been doing the second Wednesday for, we are going on, let's see, this I think will be starting year 12 in November, which is a little crazy. So 12 years of webinars. And we could try to mix things up, so we're curious your thoughts on that. I will remind everyone, do not forget the eclipse on August 21st. It has been on my calendar literally since 2000. I sent a meeting planner to a bunch of colleagues here because many of us are nerds. Not all, but many. So I think, let's see, Katie, Catherine, Marguerite, and I want to just say thanks. If you have questions, you can email any one of us. Oh, if we advance to the last slide, you can see our smiling faces and our emails. You can always call us or anyone else in the group. We're happy to help. So thanks for signing in.
Thank you.
Thanks, everyone.
Thanks.